Hi, I'm Randy Martin with the Marcus Heart Valve Center at Piedmont Heart in Atlanta, and I'm really pleased to be joined by Denisa Muraru. Denisa is from Padua, a very famous medical center in Italy. I think the oldest medical center in the Western world.
Yeah, you're right.
And you know, Denisa, the Italians bring us great food and great fashion, and now you're going to bring us great knowledge about the tricuspid valve.
I hope so.
Tricuspid valve has increasing importance as we move in mitral and sort of structural and valvular heart disease. Show me a little bit about the anatomy and function of the tricuspid valve.
Okay, with pleasure. So now the tricuspid valve indeed is no longer the forgotten valve as it was called. So I think that echocardiography has a really great potential to assess the anatomy of the tricuspid valve, and especially the 3D echocardiography. I think it's wonderful for identifying the morphology of the tricuspid valve. So it is important to know that the tricuspid valve is not only the leaflets. We should take a broader perspective.
So it's like the mitral.
Exactly.
You've got annulus, chordae, papillary
exactly.
muscles.
Also the function of the right ventricle. So it is important to consider them in interdependence, and the dynamics of this interaction is very important for studying the tricuspid valve. So the tricuspid valve is the largest of the valves.
Okay.
And sometimes it is important to know this because when you are manipulating 3D data sets, you might get lost.
Okay.
So identifying which is the largest one may help. And also the most caudally located among the valves.
So it's more toward the apex of the right ventricle.
And this is important because sometimes in a congenital heart disease like in Epstein, the septal insertion of the septal leaflet is much more displaced towards the apex than the mitral valve. So this is an important detail to consider.
Okay. Okay.
The leaflets are a little thinner because there are lower pressures on the right heart than on the left, and this may pose some challenges for imaging when you use 3D. So you need to pay attention for the gain regulations and so on. But the good thing is that when tricuspid valve is a diseased valve, the leaflets are thickened. So this is an advantage
for us. But not good for the patient.
Exactly.
Okay. All right. Good.
Another advantage is the fact that having a large data set that we can slice in whatever way we want, we can obtain real anatomic images that are very similar to the anatomical specimens that you can see from this slide.
So on your left panel you have the right atrium and obviously the right ventricle. Which leaflets are we looking at there? Can you tell?
I cannot tell.
Hard to tell.
It's hard to tell.
Okay.
And this is one of the important messages to know.
Correct.
In one slice, you cannot tell which are the leaflets.
Okay, good.
And it is another important characteristic of the tricuspid valve is that it is separated from the pulmonary infundibulum, and this is different from the mitral valve because with the mitral valve there is a fibrous continuity between the mitral and the aorta, and this is not the case. Not the case for the tricuspid valve.
Yeah, you can really see that very nicely there. Okay.
This is a 3D data set that shows the relationships between the different valves. So you can see here the tricuspid valve on the right, and you can also appreciate that there are 3 leaflets. This is the so-called surgical view. So we are in the right atrium and looking down.
Looking into the tricuspid orifice.
Yeah.
Okay.
And we can appreciate what I was saying before, that it is slightly larger than the other valve from the left.
Correct.
As you can see here, this is the mitral valve. This is the intra-arterial septum. And here anterior is the aortic valve, and here is the pulmonary valve. And this is important to know. As I said before, there are no labels when you are dealing with 3D data sets to say to you which is the medial part and which is the lateral part.
Okay.
So you should be really careful and to know these anatomical details when identifying the leaflets or pathologies.
Okay.
Another important advantage of 3D echo is this possibility to show the 3 leaflets in a single view. This is the greatest advantage. With 2D echo, it is really difficult to have this kind of view.
Absolutely.
And sometimes it is possible, for instance, with subcostal, if the patient has a good acoustic window from subcostal view, it is possible. However, the difference is that you cannot obtain the surgical view with 2D echo. You are always seeing the tricuspid valve from the ventricular side.
This, your left panel really shows us a transthoracic three-dimensional image. Is that correct?
Exactly.
Because we have the interventricular septum that separates the mitral and the tricuspid.
Yeah, it is a transthoracic data set. The tricuspid valve is seen from the ventricular perspective in this case. And here I have put this image here to show that you can appreciate the crossover between the LVOT and RVOT.
Correct.
And here is the LVOT that shows right next to the mitral valve, and here you can appreciate the pulmonary valve.
That's very nice. Okay.
So the greatest advantage that now we have at hand with 3D echo is the fact that the feasibility of obtaining this kind of image is much higher than in 2D, and it is almost 85% of the patients with transthoracic echocardiography, and I think this is a really important thing. Now that we are able to see it better, we see different aspects. And the funny thing about the tricuspid valve, how many leaflets does it have? And it is maybe a surprise, but sometimes you may find 2 leaflets or you may find 4, and there are some papers describing up to 6 or 8 leaflets. So this is kind of characteristic for the tricuspid valve because it has a greater variability than the mitral valve.
Really?
Yeah.
That's interesting. That's
So
interesting.
it should be known because it is not a congenital abnormality, it's just an anatomical variant, and it should be...
Interesting.
Yeah.
Interesting.
And this cannot be appreciated by 2D echo.
Do you have any idea how often that occurs? If you had 100 tricuspid valves, would 0.5% of them have variability, or would it be even less?
Yeah, they are a minority, but they are.
But it's there.
Yeah.
Okay, and it's interesting you said it's not associated with congenital anomalies, it's just an anatomic variant.
Now, the
Very
tricuspid valve is still tricuspid
Okay.
in a majority of patients.
Okay, that's good.
Okay. Here are again 2 images of the tricuspid valve seen on FAS. The one from the left is showing the tricuspid valve from the right atrium.
Okay, so this is back to the surgical side view. Okay,
exactly.
correct.
Here we can appreciate also the right atrial appendage. So here is the aorta, and here is partially visible the mitral valve.
Okay.
And here is the same image on the other side, on the ventricular perspective, that shows the anatomy.
So Denisa, if I was looking at this, would point out to me the septal leaflet. I could do it, but you're the expert on the surgical view.
On the surgical view,
That's
here
the
it
septal
is.
leaflet, and you can see it on your anatomic specimen. And then where would be the anterior?
The anterior would be
Right
here.
there, correct.
And the reference point is the aorta.
It's the aorta, correct, and that's very nice. So, and then over here, it's the ventricular view, but it's the same thing. You see the interventricular septum, that's your landmark.
So you see the crescentic shape here.
Right.
So this is the septum, this is the mitral leaflet, so
Right.
this is the septal tricuspid leaflet, this is the posterior, and this is the anterior because it corresponds to this RVOT.
Very, very nice. So it's like people have to get used to thinking the echo people as they're just talking to their surgeons with these anatomic landmarks, and so and you've got this very, very nicely here.
Yeah, and actually the surgeons are very like these images and are much more familiarized to see this kind of anatomical images than the echocardiographers who are confined with the slices and the 2D views.
Excellent.
So here we have a case just to show how difficult it is sometimes to identify the leaflets. Here is a patient, 31-year-old woman. She's an IV drug abuser. Okay. She presents with fever. She evidently has severe tricuspid regurgitation. And the question would be where it is inserted is large vegetation. You see there are several examples of the tricuspid valve seen in 2D, in parasternal.
Parasternal short axis in the upper right.
Here.
Okay.
Here is another parasternal
RV inflow tract.
Exactly, and here is the
apical four-chamber view.
And it is quite difficult to identify which leaflet is involved because we are only seeing just 2 of the 3 leaflets.
Got it.
One, and we don't know which one are they. it would be much more easier to see them all together and to pay attention to the anatomical landmarks. We can appreciate where is the septum.
That's
exactly.
Interesting.
Yeah,
that's very, very nice. Now, Denise, if you went back, go back to your 2D echoes. Can we tell now, knowing that? Do we know which leaflet's which here? Do we see? Obviously, we don't see the anterior leaflet in the apical four-chamber view, do we? Down here, and I mean, we see the prolapsing mass, but we're not seeing it as well. So,
yeah,
it's difficult. It's very difficult. It's great. So go back. That's very nice. Okay.
And in fact, this is quite evident if you would be curious enough to look to all the textbooks. My colleague Ivan Stankovic did that, to all the great textbooks that teach us echocardiography and the guidelines. There is a great confusion of what leaflets they teach us that we should see in each view.
Yeah.
And actually the worst was the right ventricular inflow view, because all scenarios were
Everybody's got different labels. Isn't that interesting?
Yeah, and the reason for that is the fact that we are not able to tell in a single slice which leaflets we are seeing, because there is no anatomical landmark that tells us which leaflet is anterior and which leaflet is posterior. This is a data set.
But aren't you saying septal leaflet? You can identify the septal leaflet at all times.
The septal, yes.
Okay.
The problem in four-chamber view is the lateral one, which is anterior or posterior.
Correct.
And you see, this is the same patient, the same 3D data set, sliced in a different way. In the first, this yellow line corresponds to this slice, the four-chamber view. Okay. And here you can see that the yellow line crosses the septal and posterior. And you cannot perceive any difference in visually.
So the upper one is going septal anterior, and the one at the bottom is septal posterior, but they look the same in the 2D image.
They look absolutely the same.
That's a great demonstration.
And this is holds true also for the parasternal view. And this is why we cannot identify with a 100% certainty from a single slice which leaflets are we seeing.
Excellent, excellent.
So the leaflets would be important to see very well, and the way to do it is to see them en face and all three in the same view. Okay. Because this is the element that discriminates between the two major mechanisms of tricuspid regurgitation: the organic, in which the leaflets have structural abnormality, and the functional, in which the leaflets are normal, but the problem is the annulus and the dilation of the right ventricle and the tethering. Okay. So it is important to see very well the leaflets and see them all, to see the commissures and so on. Here I have another case to demonstrate this. So it's a patient presenting with heart failure, with clear lungs in atrial fibrillation. He had a VT run, an unsustained VT run, and was sent in Padua for suspect of arrhythmogenic cardiomyopathy. Okay. So these are his images. Four-chamber view, huge dilation of the right heart with a lack of coaptation, a free-flowing tricuspid regurgitation, severe one. Severe. But we cannot perceive any structural abnormality in these views of the tricuspid leaflets. They seem quite tethered.
Yeah,
but
you'd look at this and say this is functional. Functional.
Yeah, a very, very enlarged atria, but this is functional. And the conclusion would be, if the patient is symptomatic, that he should undergo a tricuspid valve annuloplasty based on these images. However, we dared to do also 3D, even if the patient was in atrial fibrillation. Okay. And we took this data set. Here on the left you see a data set taken from the apical approach. We see the tricuspid valve from the apex. And here we see the septum, so this is the septal leaflet. Posterior leaflet, we see the margins very well. Correct. The anterior leaflets, I cannot see very well the margin here, and if you can appreciate here, there is a vibrating structure.
Correct, I see it.
Yeah, and if you cut exactly at this level, like this, in longitudinal view, you can appreciate that there is a clear flail of the anterior leaflet, and you can even notice a rupture cord there.
That's interesting. See, I would have never judged that from looking at the transthoracic.
Yeah,
ever.
In fact, patient had a long-standing history of right heart dilation, but the primary cause was never known.
So he probably didn't come to clinical attention until the right heart was very big. So, you know, and this is interesting because a lot of causes of a failed tricuspid valve are deceleration injuries, automobile accidents, falling off of a ladder, falling off of a horse, and they often don't come to attention until years later.
Exactly. And this is the case with this patient because when he was on the scanning bed, we tried to understand what happened. Did you have endocarditis, fever, and so on. And barely he remembered that when he was a child, he had been caught in a tornado and he had been hit against a wall, so and he had a chest trauma.
See, I'm smarter than I look. That's fabulous. I mean, that's a great case because I would have never judged that on his transthoracic.
And on the chest X-ray, there was a healed rib fracture. So
fascinating case.
A good trauma.
Case.
So it is important because actually in this case you would not do any more annuloplasty. You should change the valve, and in this case the patient did that. Why didn't we see the leaflet that was diseased in the two-chamber view? This is just to emphasize how you obtain the four-chamber view. This is a 3D data set, and this slice corresponds to the four-chamber view and corresponds to this line.
So you're doing septal posterior.
Exactly.
And the four-chamber.
And you miss the anterior, and you do not realize. If you would look in the orthogonal view, you would see it here.
That's fabulous.
And the same holds true for the parasternal. Again, we were seeing the posterior and the septal, and we were missing the anterior, and we didn't even realize it. So the message is the fact that when you are not seeing all together, you may think you have seen all the leaflets in 2D, but you have no certainty.
Very, very good. Excellent case.
This is the outcome afterwards.
Yeah, that's interesting.
Another cause is the rheumatic tricuspid valve disease. And we know the features, characteristical thickening of the leaflets with the doming, as you can see from this image here, restricted motion.
Right.
We are not able to see on 2D the commissures, and this is something that can be seen very well with 3D. And this is a case of a patient, 46-year-old woman with a rheumatic mitral stenosis.
Certainly.
And we see here that there is a severe tricuspid regurgitation.
And there's also alicing on the right image, so you know that there's some degree of obstruction in the tricuspid orifice during diastole.
Yeah, it's true.
Okay.
But seeing here doesn't look
like it.
Yeah.
No, that's what I'm saying. There's a mismatch between what the color is telling me and what I'm seeing.
Yeah, and one may pay attention only to the regurgitation and might be caught to quantify the regurgitation and may miss the stenosis. Right. But what you can do very easily is to take a 3D data set that helps for two purposes. One, for obtaining more reliable measurements of the right ventricle with 3D, but you can also look on the morphology of the valve on the same images. So this is a multi-slice display of the data set. So these are transversal slices across the tricuspid valve that you can appreciate here in short axis view. This is the septal leaflet, the posterior and anterior, and look how thickened they are.
Right, you can see that. Yeah, you really begin to appreciate that.
And also the commissures that are not opening quite well. Do you agree?
Yeah, yes, very much so. But I mean, I didn't. Again, it's lack of familiarity with these images initially, where you don't think about that way. But no, absolutely.
This is one way to do it. In multi-slices are 2D images that are taken like in CMR, for instance.
Right.
You can take them very, very close to one another and identify the smallest orifice, and then you can planimeter.
So you're coming up to really the tip of the orifice there to planimeter it.
Yes, you should be really careful how to orientate these planes in order to be parallel with the opening. Even if it's an eccentric opening, you should align these slices in order to have a correctly anatomical planimetry.
That's great.
This is an important thing to do for the tricuspid stenosis because the parameters for quantifying the Doppler parameters for the mitral stenosis do not necessarily apply on the right, and this is something that we cannot do with 2D echo.
Yeah, that's very, very nice.
Another way to do it is to do it on the rendering image that you can stop in the frame that displays the maximal opening.
So you're using your 2D image to know where the tip of the leaflets are,
yes.
where the orifice is,
Exactly.
versus cutting through the base of the leaflets.
You place them really carefully at the
Okay.
tip of the leaflets,
So,
and then you measure.
Denise, is this easy to do once you figure out how to do it? In other words, you're doing this online, so you can do this
on
right
the scanner.
now?
On the scanner.
Okay.
Yeah, you can
okay.
do it on the scanner. You first acquire the data set and then you post-process
Okay,
it, but it
okay.
takes just 1 minute to
Good,
do all the
good,
quantitation.
okay,
Really,
okay.
really easy.
So let's move to the tricuspid annulus. So we need, because this is the question that we hear. So you've taught us a lot about identifying leaflets. The question always comes, tricuspid annular size. Should this patient have patients having mitral surgery, should the patient have something done to the tricuspid? Great confusion on when to measure, where to measure, and accuracy of those measurements.
Completely true. And this is really, really important because the greatest proportion of patients with tricuspid regurgitation have a functional mechanism, and they are more and more increasing, especially now that we are treating the valves on the left with TAVI or TAVR or mitral clip. The tricuspid valve remains unsolved, and this may become a problem. So the tricuspid annulus has a saddle shape like the mitral valve. So in some way it is similar, but it is also different because the saddle is different. So it is much more rounded, and
Okay.
the mitral annulus is more elliptical.
Okay.
And during the cardiac cycle, the dynamic changes in diameter, it changes much more in septal lateral dimension than the mitral valve.
Okay, so it's septal lateral is where the dimensions change.
Yes,
Okay.
and this is important because we have already some tools that were developed for quantifying the mitral annulus, but this is one good reason to understand why this software cannot be applied for the tricuspid valve.
Good.
So one way to do it is to take a data set that we have seen how it can be acquired and just place again the short axis exactly at the opening of the orifice.
Okay.
And then after you obtain a short axis projection of the saddle,
Okay.
you can take the measurements, linear dimensions, and you can also measure the area.
Okay.
You can appreciate on this short axis of the tricuspid annulus that it is not rounded, and it's actually elliptical. And another important message to take in mind is the fact that the four-chamber view, which is in this image here, corresponds to this yellow dashed line,
Right.
does not correspond actually
the
neither
maximal.
to the maximal nor to the minimal. It's just
Interesting,
one of the many
interesting.
diameters.
Okay, okay.
And this is probably one of the reasons why our possibility to quantitate the tricuspid annulus with 2D echo are not that
It's
good.
limited. Yeah, absolutely. So what about 3D?
With 3D, we have something more. We can have a 3D data set and then obtain these short axes and take several measurements. This was actually very difficult to do because they are manual measurements, not having any software that
Correct.
provides these measurements. So we took 5 moments of the cardiac cycle to understand the behavior in the normal subjects. And we have understood several things. The fact that it is highly dynamic, so it changes a lot, 40% fraction area change during the cardiac cycle. And this means the first thing is that it really matters when you are measuring, because it's something to measure in systole, it's something to measure in late diastole when it reaches the largest diameter. And we don't know yet which is the best moment.
So, these are obviously healthy subjects, so these are not pathologic ventricles or anything, but you're saying that you think that the largest is in late diastole. That's your feelings from this?
From this, in late diastole.
Okay.
So probably changes in pathological hearts are less pronounced because the healthy hearts have also sphincteric contraction of the annulus. But most importantly, apparently the changes in linear dimension in an anteroposterior dimension are different than a septal lateral dimension. So it's not a uniform change of the annulus.
Are you saying that it changes more in the AP than the septal lateral?
Exactly.
Okay. Okay. I think I'm getting confused, but keep going here. Maybe it could straighten me out.
And we've seen that if you want to see which are the determinants of the annulus size, not only the body size, but also the right ventricle as it should be.
It makes sense.
Exactly.
That makes sense. Okay.
And we've seen that the area of the annulus is a little better correlated than the diameters, probably because the diameters are difficult to,
correct. I got it.
to orient.
I got it. Okay, that's very good.
The dilation of the annulus is important. It is the most important mechanism of the functional tricuspid regurgitation. And the problem in quantitating this bilinear dimension are related to the fact that when it becomes larger, it does not become larger in every dimension, but only in the posterolateral.
So it's really going from, is the dimension going from the commissure edge between the anterior and septal out to the free wall?
Exactly.
So it's really going the way your arrow in the bottom right is pointing.
Yeah.
So is that what we should be measuring?
Yeah, but it's difficult to identify it in a 2D slice looking at the annulus in a longitudinal way. It's easier to do in a short axis view, obtainable by 3D, but in 2D is rather cumbersome.
Okay.
So this is an example just to pinpoint how we can size the annulus in clinical practice. This is a young patient with a severe rheumatic mitral regurgitation with heart failure, and before surgery we should also take a look at the tricuspid annulus and to identify the mechanism of tricuspid regurgitation. It is organic, it is functional, and how it is the annulus size. And the guidelines, of course, recommend to obtain the measurement in the 4-chamber view in diastole, and the cutoff for annuloplasty is 40.
Mm-hmm.
In this case was 39, so it was a bit questionable.
Maybe to you, but no, I understand what you're saying. Go ahead, that's fine.
Yeah, probably it was underestimated.
Right.
And here with the 3D echo, we can see that the leaflets are thickened.
Correct.
And there is a clear regurgitation orifice here.
You can see failure of coaptation. Yeah, very
and
much
this
so.
explains.
Septal leaflet really looks like
it's severely tethered.
Right, absolutely.
This can be appreciated here much better. This is the ventricular view on the left and the atrial view on the right.
Correct.
And here it's a demonstration of the fact that you can use the data set also to eliminate doubts. For instance, if you are having some doubts of this bulging here, if it's prolapse, you have some questions whether the leaflets are normal, you can place your slices like this and you can see what happens in the longitudinal views. And we see that there is only tethering and the leaflets look structurally normal. So the mechanism is clearly functional in this case. You can also obtain a short axis view of the annulus and you can size it.
Okay.
And we have obtained that indeed the largest diameter when taken from 3D is 42, so it's clearly dilated. Beautiful images can be obtained, and this is the same patient.
Same patient, yeah. So that you can see it both on your left panel is the ventricular view, is that right? And the right panel is the atrial view, so you can see the tethered septal leaflet. I really appreciate it more in the atrial view, where you can really see that it's not it's
not
really
moving.
tethered.
Practically, it's fixed. Yeah. And again, you can do the same thing for measuring the annulus from the transesophageal approach, and the measurements in this case are pretty similar with the ones from transthoracic. The message would be that if you have a good image quality from the transthoracic approach, it may be enough, and you can wait for the patient to go into the surgical room and do the measurements with the TE while the patient is sedated. This is the outcome after the surgery. There is a problem with these measurements taken on 3D data sets. So I said before that the tricuspid valve is not flat.
Correct.
It's a saddle. So when we are doing these measurements, we are measuring at different levels. We are assuming that it is projected on a flat plane. And this is not actually the best way to understand the behavior of the tricuspid annulus. Ideally would be to have automated software that allows us to identify the dynamic changes throughout the cardiac cycle and to overcome also the variability from manual measurements, because there is also the problem of the operator, how you do the measurements, how you regulate the gain and so on. So all these things would be much more easier if you would have a dedicated software to perform all these measurements.
Okay.
It's not
not available for prime time yet, as I say.
No, it's a prototype, but we have good hopes that something like that will be available in the future.
Very nice, very nice. So, Denise, the take-home message to me is that tricuspid valvular anatomy, identification of the valves, 3D, clearly helps dramatically. And it teaches you to understand why 2D echo, you have some limitations. Annular size, I'm still a little perplexed. So if you're telling me, you're teaching me, what views do I need to get and when do I need to measure the tricuspid annulus with all the problems you have? I mean, would you measure it? You're saying in diastole or in diastole, but isn't in systole the measurement the surgeon wants to know, because that's when the valve should be competent?
Absolutely, but I cannot give you the answer right now. We need to have data to see which one is more predictive of the late tricuspid.
Is it better to measure the annulus from a 3D data set?
Theoretically, yes, because at least we have the possibility to control what we are measuring. If we're measuring actually the maximal or the minimal.
Let me ask you, and I'm sorry to cut you off, where I've been convinced that if I'm doing a transesophageal echo and I do a transgastric view, 60 degrees or so, then I can see all three leaflets of the tricuspid valve in most people. So I'm seeing all three leaflets, so I can begin to measure things. Does that make sense? I mean, obviously I'm doing a TE in people.
Of course, but this is the problem. As I said, if the images are, if you have a good acoustic window from transthoracic approach, and you need only one, usually the apical works good, I think we can save a lot of
But you've got to see all three leaflets is what you're telling me. So you really need the
3D.
Well, even with 2D, sometimes you might, if you had, but then you've got, like you showed it earlier, but then you've got a dilated right ventricle, so you can get all three in there. Well, this has been, I mean, this is very, very informative. It's very well done. You've taught me a lot. You've left me with some questions here. I'm still uneasy about how I'm going to measure the tricuspid annulus, because that's what the surgeon is asking me time and time again. And so I mean, maybe your software will help us with that and everything else, but very, very informative.
We hope so.
Yeah.
We are looking at and we are working on to give you an answer.
Good.
The next
Thank
time.
you. Denise, thank you so much for taking the time to teach us. And thank you for watching. I hope you've learned as much as I have.
Thank you.